Welcome to our special live streaming series, COVID-19 Frontline on CGTN. I'm Zhou Yun. COVID-19 Frontline is a special live show which offers a platform for medical experts from China and around the world to share their thoughts and experiences in fighting and containing COVID-19. And apart from expert discussions, we also take questions from followers on various social platforms, including CGTN app, the official website, CGTN official account on Facebook, YouTube, Twitter, and Sina Weibo. So feel free to leave your comments and questions on those platforms with the hashtag of my opinion on COVID-19. We look forward to your participation. And today we have a special array of guests from China and also Mexico, and also all the doctors from the Chinese site come from Peking University First Hospital. They all have the experience of fighting in the front line of Wuhan, which was the epicenter of China's outbreak here. And now it is my great honor to introduce to you all of them. Well, first of all, from China, we have Dr. Li Haichao, who's the Vice President of Peking University First Hospital and also Director of the Internal Medicine. So thank you so much for joining us, Dr. Li. And also we have Dr. Wen Haoyu, who's the attending physician from the Department of Cardiology, also from the same hospital, and also Dr. Hu Zhanwei, who's the attending physician from the Department of Pulmonary and Critical Care Medicine, also from Peking University First Hospital. So thank you so much, gentlemen, for joining us. And also it is our great honor to have three gentlemen joining us afar from Mexico, and they are also from the same hospitals, from the National Institute of Medicine Sciences, Medical Sciences, and Nutrition, Salvador, Zubiran. So first of all, we have Dr. Guillermo Dominguez, who's the head of pulmonary anesthesia and critical care medicine at from the hospital. And second, we have Dr. Carlos Torruco, who's the critical care medicine specialist and attending physician at the National Institute of Medicine, Medical Sciences and Nutrition, Salvador, Zubiran. And last but not least, we also have Dr. Juan Gutierrez Mejia, who's the Disaster Reaction Planning Department, also from this hospital. So thank you so much, everyone, for joining us today. And without further ado, I would like to give the floor to our guest from Mexico. So, gentlemen, if you have any questions to the doctors here in China, please feel free to go ahead. So, yes, Dr. Torruco, so do you want to start? Sorry, you're now muted. You need to unmute your audio first. Thank you.
Yes. I would like to ask a question about using... recently, there have been some controversy about the dosage of anticoagulation in COVID-19 patients. Do you think it is proper to use prophylactic or therapeutic dosages of anticoagulation? Mm-hmm. What's your opinion about that?
Let's see, because I'm not sure, like, we fully understand the question. Let me check with Dr. Li, because there were some disruptions from the audio. So, Dr. Li, did you get the question?
No, not very clear about the questions. Yeah, sorry.
I'm sorry.
Simply,
yes.
Do you prefer using anticoagulation at prophylactic or therapeutic dosages?
You mean the anticoagulation therapy?
Yes.
Yes, I get it. Yes, I think the Dr. Wen Haoyu could answer these questions.
Yeah, thank you for the question. Yes, we use the prophylactic and therapeutic anticoagulation in our experience. I think there are a lot of research nowadays to show there's a high risk of VTE or pulmonary embolism in severe and critical COVID-19 patients. And there are also some research show that elevated level of D-dimer is associated with higher mortality, and the patients with anticoagulation had a better prognosis. And there's a very interesting research in New England Journal, which is published in New England Journal of Medicine. It's a pathology finding, and the pathology finding showed the COVID-19 patients have endothelialitis. I mean the inflammation of the endothelium cells, and there are a lot of microthrombi formation in the capillaries. So this can explain why a lot of patients have an extremely high level of D-dimer, but without findings of VTE or PE. So we recommended anticoagulation in patients with significant elevated D-dimer level or with detectable thrombus. And we should exclude the contraindication like severe thrombocytopenia and significant prolonged prothrombin time or active bleeding. And we usually choose low molecular weight heparin for the most of the patients. And the patients with CKD or decreased EGFR, we decrease the dose of the heparin, the low molecular weight heparin. And for patients with suspected HIT, we use the rivaroxaban. That's my answer.
Okay, thank you very much.
I have some opinion about these questions.
Okay.
I agree with Dr. Weng. You know, we think something happened in the lung. It's organ-limited, maybe DIC occurred in lung because the patient have a very severe hypoxemia, but some patients didn't have haven't had a typical ARDS. So it is found that the macrothrombosis occurred in capillary of a lung. So I think anticoagulation is very important to improve the very severe hypoxemia. So that's my opinion. Thank you.
Okay, thank you very much. So how do you define severe elevations of D-dimer? What's the concentration above which do you use therapeutic doses of anticoagulation?
Well,
so you mean how we define the significant elevated D-dimer? Yeah.
Yes.
I think more than 5 is significant elevated.
5 times. Oh.
Yeah.
Okay.
5 times. Yeah.
Deeper level. Okay. Thank you very much.
Okay, thank you. So I saw Dr. Huan is raising his hand. Yes, Dr. Huan, please kindly go ahead.
Thank you very much. First of all, because this is an extraordinarily good opportunity to have this feedback from some people who are so experienced like you. So I have a question regarding, did you run out of medications in certain moment during the surge of this demand of patients at your hospital? And in that case, how did you handle this?
Sorry, I missed the important.
So the question is, did you run out of pain or hypnotic medications taking care of your patients during this pandemic? And in that case, what did you do to resolve this problem? Because in Mexico, for example, nowadays we are running out of medications to treat our patients. There's no amount, you cannot get it in the market. There's no way to buy them, even if you want. So it's a resource that is lacking in this moment. And then there's a problem how to sedate the patients, how to treat the pain, how to keep them in prone position without fighting with the vent.
Okay, so
不然为你听楚了吗？
Okay. Thank you, Dr. Huang, for your question. I understand that you're asking about the shortage of medications, right? Yes, we did have a shortage of medication when we first arrived at Wuhan in January this year. But most of the short medications are related to the basic conditions of the patient. For example, medication, drugs for hypertension, drugs for diabetes, and drugs for heart diseases. But most of the time, we can find some alternatives for the drugs, such as when the patient uses one hypertension drug, we don't have this, but I remember we only had one type of hypertension drug in our hospital. So most of the time we had alternatives. As for the treatment of the COVID-19, so far I think there are no drugs, no definite effective drugs to treat COVID-19. So I think that is not a very serious problem. But there are some drugs that are truly very important. For example, antibiotics, glucocorticoids. I think those drugs sometimes those are indispensable. Thank you.
Okay, thank you, Dr. Hu.
Thank you.
So now let's go to Dr. Dr. Dominguez, do you have any question?
Yes, how frequently do you use the non-invasive ventilation on patients with COVID-19?
The non-invasive ventilation, right?
Yes.
Okay.
Yes.
So our doctors from China, so who can answer the question about the invasive ventilation, right?
No, I mean you mean non-invasive ventilation,
Non-invasive,
right?
sorry.
MPPV.
Yes.
Right, non-invasive, yes.
We use a lot of MPPV in our ward, and many patients in our ward are severe or critical. So we think now MPPV is very useful for respiratory support in these COVID-19 patients. And when some patients may get very severe during the treatment, and sometimes when using MPPV, we can use some sedation drugs. And maybe Dr. Li has more experience in treating this kind of pneumonia using MPPV because he also experienced the 2003 SARS epidemic.
Mm-hmm.
And we
yes.
think MPPV is very useful.
Yes, to use MPPV to treat COVID-19, it's dependent on the experience of our work in 2003. It's about SARS treatment. It is believed that the mortality of SARS is very higher than COVID-19. But during that time, we use mainly with MPPV to treat the very severe SARS patient, and we got a high successful rate. And during this time, we use MPPV to treat COVID-19. We think it's very useful to treat the patient. And for MPPV, it have a lot of advantage compared with mechanical ventilations. The patient keep awake and they can feel some discomfortable, and the staffs can come to see the patient. And also there are a few ventilator-associated pneumonia happened in our ward. And also, because some patients have a very severe hypoxemia, when patient had intubations, sometimes maybe a sudden death occurred. But for the NPP, we haven't had such kind of situations. But I think if you use NPPV, you must keep close observation on the patient, and you should not suspend treatment of NPPV, not stop it. So you may let the patient lie down on the bed and to use a urethral and a gastric tube. So I think NPPV is most useful for the treatment of COVID-19.
Mm-hmm.
And also NPPV can be performed on the general ward, not in intensive care unit.
Okay.
And do you have a special kind of interface? Do you prefer mask or helmet? What do you use?
Sorry?
So
we only had masks. We didn't, helmet was not available during the epidemic in Wuhan. We only had mask, this kind of mask.
Yeah.
Okay.
N95 masks when we work in our ward.
Mm-hmm. So, Dr. Lee, since you mentioned that you were in this fight in 2003 when we fight SARS, and also I know you were in the medical team sent to Indonesia due to the tsunami broke out, right? So, and also you were in frontline of Wuhan fighting this pandemic. So, can you share a little bit of your personal experiences with us about how different is the outbreak that, in your opinion, this time? What are the most distinguished characters according to your personal experiences? So, Dr. Lee? Did you hear me? I'm sorry, it seems we can't hear you, so can you still hear us? It seems that we lost your audio, Dr. Lee. Dr. Lee, can you hear us? I'm not sure whether we can still hear Dr. Lee. Okay, now I saw Dr. Juan raised hands, right? And also Dr. Carlos. Let's first go to Dr. Juan, and then we can go back to Dr. Carlos. Yes, Dr. Juan.
Hi, so we've read about Wuhan, where they have a high rate of nosocomial infection between healthcare workers, up to around 41%, taking into account family and patients that were in the hospital, and also healthcare workers. So how was your experience in your hospital regarding healthcare workers' infection? And how did you handle this to decrease this amount?
Okay.
Okay, Dr. Han, I will answer this question. Mm-hmm. Yes, there are some doctors and healthcare workers infected with COVID-19 in Wuhan. We went to Wuhan on January 26th, and as far as I know, most of the health workers infected with COVID-19 happened before we went there,
Right.
and most of them are local health workers, local Wuhan health workers. And I think the most important reason is because when this epidemic happened at the end of last year, most health workers, most doctors, they don't understand what happened, what this disease is about. So they were not fully protected. Maybe some doctors in the clinic, they didn't wear a mask. And many of the doctors infected, they are not specialists in pulmonary or critical care medicine. Some are enterologists, some are ophthalmologists. So I think the understanding of the disease is very important. And in the epidemic of Wuhan, many doctors and nurses, about 40,000 health workers went to Wuhan from all around China. Mm-hmm. And as far as I know, nobody of these doctors and nurses, no one was infected with COVID-19. So standard protection is very important. Yeah.
So
Thank you.
Can you give us a few examples, Dr. Hu, about, I think you're right. Among the over 40,000 people or medical experts sending from around China to Wuhan, I think the infection rate among those doctors, which was actually 0. So can you give us a few more examples about the standard that you said? What do you mean by standards? What makes those medical workers fighting in the front line being well protected?
Yes. Just like we can see on the media, we can see on the TVs, doctors when they see COVID-19 patients, they are well equipped. They have personal protection equipment such as the protective suits and glasses, and sometimes protective helmets or head cover, and N95 masks, and also gloves. So from the head to the feet, all covered. So the chance of getting infected is very low, I think.
Okay, thank you.
Can I say something about that?
Yes, please, Dr. Li.
Yes, because all the staffs care about the protective equipment. I think N95 is very important to help to protective of aerosol transmission. But the common transmission for the COVID-19 is droplet transmission, contact transmission, and aerosol transmission. But aerosol transmission only occurred in some limited conditions, such as you may in a very closed, tight space that aerosol transmission can occur. So it is suggested that the surgical mask is enough to protect. It is suggestion by the WHO. But if you have enough N95, it's more effective than surgical masks to protective aerosol transmission. But if you have a very good condition in your workplace, that the aerosol transmission is seldom occurred. So I think maybe at that time, the surgical mask is enough. Thank you.
Okay, thank you so much, Dr. Li, for adding up those very useful information. And now, yes, let's go to Dr. Carlos. Dr. Carlos, please feel free to go ahead.
Thank you very much. Do you mention that you are using non-invasive ventilation and high-flow nasal cannulas in the general wards? Do you take, what measures do you take to prevent the aerosol spread of COVID-19 to personnel, to healthcare personnel, or to other patients?
Can we?
Yes, we did use MPPV and high-flow nasal cannula in general ward. You mean how do we prevent the infection?
The aerosol, yes, the spread, the aerosol transmission to the healthcare personnel.
我来回答这个问题，要吗 ？Okay, I know that some experts worried about the aerosol transmission during NPPV. But actually, I think it's not so severe, because in our world, in the very busy time, we have 10 person to adapt to the NPPV at the same time, and all of our doctors and nurses use PPE, just PPE, not use very good equipment to protect personnel. And also we have installed fan in the windows of ward. So it is helpful to improve the ventilation of the ward. So I think keep very good ventilation is very important to protect for the aerosol transmission. It's very important, not N95.
Okay, thank you very much.
Okay, thank you. So, Dr. Dominguez, do you have more questions? Please.
Yes. Now it's after 3 months after the peak of the cases of COVID-19, Have you seen frequently pulmonary fibrosis, and how are you treating these patients?
展维，你来说还是我来说？
How frequently are you seeing now pulmonary fibrosis post
I try to answer this.
pneumonia?
Yes, I try to answer these questions. I think the so-called pulmonary fibrosis only occurred in the patient recovered from the very severe situations, such as a very severe or critical ill patient. And after they recovered from their very severe conditions, the oxygenation must be getting better, although there are a lot of shadows in CT scan, which is similar to the pulmonary fibrosis. But if you keep observe of such kind of patient, you can see the oxygenation maybe become better and better, and the shadows on the CT scan may be absorbed. So we think that such kind of shadows, which is the mimic of lung fibrosis, but actually it's a repairment process of pneumonia or ARDS. We observed that a lot of lesions can be observed in the futures, which is the same as SARS. So it's our suggestion that to give the patient regional oxygen therapy, that's enough. You can observe. If the patient's situation is not so good, because some patients may be recovered not so quickly, you may try some drugs, and you can refer to the treatment of idiopathic pulmonary fibrosis. But I think most of the patients can be recovered slowly. Thank you.
Mm-hmm.
I agree with Dr. Li for most of his, because it was reported that during SARS, some patients might have a residual lung function decline after the infection, but in COVID-19, as we have observed, it maybe the proportion of patients who have pulmonary fibrosis is not as high as we think. Some kind of drugs are useful for preventing the fibrosis process, such as anti-inflammatory drugs. We all know that sometimes we use glucocorticoids in this disease, and sometimes we use anti-interleukin therapy, for example, anti-interleukin 1 and anti-interleukin 6 therapy. And this might be useful in preventing fibrosis, but most of the time when you trying to treat the fibrosis, the patient is getting better and better. And at this time point, when if we use glucocorticoids, it might have a lot of adverse effects. So I think the rational choice may be to use the IPF drugs such as nintedanib or pirfenidone. That might be useful in preventing fibrosis, but we should be careful about the patient's liver function, the renal function, because in critical patients, these renal injury, kidney injury are very common. Thank you.
Mm-hmm. Okay, thank you so much. So,
Thanks a lot.
Dr. Huan.
Yes, thank you. So it's very valuable that you are at least 3 months ahead from our experience in this moment in Mexico. And I would like to figure out, how long did you treat your patients with anticoagulation after they had been discharged?
Wong Haoyu.
I'm sorry, didn't hear the question.
So after you discharged your patients from the hospital, for how long did you keep them on anticoagulation therapy? To those patients where you started anticoagulation because their dimer D levels were so high. So as you know, these levels will be decreasing as soon as they start improving. But for how long should we recommend to continue the anticoagulation? What has been your experience now that you have more patients that have been discharged than whatever we have in this moment in Mexico?
Yeah, I think for most of the patients, we discontinue the anticoagulation before he discharged. Yeah, because the standard for discharge is he don't have any dyspnea or
Symptoms.
Striding, virus striding.
Yeah, so we stabilize them and then discharge them. So we don't use anticoagulation after discharge.
Okay, thank you.
And also, when they get discharged from the hospital, we don't immediately send them from hospital to home, right? That's according to the case in Wuhan. We send them to like a quarantine center. So they quarantine for another 2 weeks before they can go back home. Is that correct, doctors? So
yes.
Okay, so I think that's what it helps. So they don't go directly from hospital to home. There's actually 2 weeks of quarantine. Stayed in either shelter hospital or no, it's not shelter hospital. It's more like a hotel. So to make sure that they are fully recovered. So
not fully recovered, but I think maybe to protect for the other persons, because we are not sure if the nucleic acid detection is negative.
Yes.
Maybe someone is false negative. So to keep a long observation for quarantine is more, I think is
accurate.
Helpful for others to think that they are recovered very well. Thank you. Okay, Sorry about that.
No, thank you. That's very accurate. Apologize, I'm not a professional, but thank you so much for adding up that. It's really, really important.
So I can figure out that you are taking care of what may happen when you discharge the patients to decrease the amount of contagion between the rest of the community. So talking about public health care strategies, what would you recommend in order to start your normal life coming back from this condition where people were at home without usual activities? So when you restart your activities, what will be your best recommendation in order to decrease the new surge of patients?
Okay, well, this is a really tough question because let's see the doctors if they have any answers or any suggestions. So, Dr. Lee.
胡大为，你能回答这个问题吗？
I think the most important thing is we should raise the public awareness of this disease and remember to wear the face masks at public places. That is the most important one. And wash your hands as soon as you get home. Very basic, very simple, but very useful methods to prevent the transmission of the virus. And also, some public places are not opened until recently in China, such as the cinema. And when you go to some restaurants, they will check your phone to see if you have been anywhere that has COVID-19 cases, to make sure that you are safe to enter the restaurant. And all these measures will make our public places safer.
Right.
So just try to see if I get it right. So you track your GPS positions to figure out where have you been with your phone?
Yes, we have an app. We all have an app on our phones that shows if we have been to somewhere that is epidemic.
Right.
Very interesting. Thank you very much.
Yeah, we have like a QR code in our phone. First of all, it can track whether you have been to those high-risk areas. For instance, like 3 months ago, whether you've been to Wuhan, right, or some other places, whether you have been in certain places where area that has been, found a large number of confirmed cases. That's one thing. And the other is whether you yourself have been infected, or you have symptoms of high fever or other infectious symptoms. So usually we have those two QR code in the phone. So every time you need to get into a public area, restaurants, gym, or other places, you need to show that if it's green, that you're good to go. If it's red, maybe you need to wait until it turns green. So that's how it works here in China. We have a very large database, to track your position and also your health condition.
And is the government the one who is taking care of this, or is the healthcare department?
I think you're talking about the same thing. That the health department and the government, in our opinion, it's the same thing. It's on the national level. It's not on like personal or city level. It's a national level. Yeah.
Perfect.
So, Dr. Carlos, do you have more questions?
Yes, I have a question. Given the global shortage of N95 respirators, what is your opinion about the use of elastomeric respirators?
So,
Well, first of all, we have never used the kind of respirators you mentioned, because we only have two kinds of masks. That is surgical mask and the N95. We have never seen a respirator like that.
Elastomeric. Okay. Thank you.
but Dr. Hu, when back in February, I think, or January, when this epidemic first started, there was like very short period of shortage of N95, right? But at that time, I think we prioritized the use of N95 to the medical workers. Like for the ordinary people like us, we just wear the very basic face mask. Was that correct? Was that something that you experienced?
Yes. And also in Wuhan, we only wear N95 when we get into the ward seeing the COVID-19 patients. But outside the ward, we also wear surgical masks.
Okay. Yep, surgical mask.
Okay.
I have another question for you.
Yes.
Just in a general perspective, from all the patients that you treated in the ICU, what percentage would you say you prone the position of the patient? How frequently do you have patients in prone position? So you just to have a ratio, to have an idea, like in a general way. Maybe in Mexico we are putting around 60 to 70% of our patients in prone position, something that we didn't used to do before in the general healthcare services.
Okay, I'm not sure we have a similar situation here in China, right? But yes, Dr. Hu, yes, please.
60 to, Dr. Huan, did you mean 60 to 70% of patients using prone position?
Those we have in our ICU, around 7 from every 10 patients will be in prone position in a certain moment during their time that they are in the ICU. And we, in our hospital, we used to keep them in prone position for several days. We don't change them constantly, like in Prusiva that they say every 16 hours.
And all the patients you use prone position, are they intubated?
Yes.
All of them are.
At ICU, I'm talking about ICU patients. We also put some patients in prone positions in the wards without intubation. And they kind of improve their oxygenation for a certain moment just to try to win a little bit of time until we have some bed available at the ICU. But in our ICU areas, most of our patients in a certain moment, they will be turned down, upside down to be in prone position. Most of them, right? Between 60 to 70%. So I just wonder, how frequently did you put your patients in prone position?
Well, that is a very high percentage. Well, we do use prone position when treating ARDS patients in our daily work, but in Wuhan, most of our patients are not intubated. And in severe and critical patients, when he or she is not intubated, I don't think he can tolerate the prone position unless it's intubated and sedated and use maybe muscle relaxants. So we did not use prone position in Wuhan, but we use prone position in ARDS patients. But I do agree that some ARDS patients with COVID-19, if they have gravity distributed lung lesions that are mainly distributed at on the backside of the lungs, they may benefit from prone position. But as you mentioned, you said that patient might be kept in the prone position for several days without turning back. I think that is not proper. Usually, I think 4 to 8 hours, you need to turn him back. But if you have, for example, it takes a lot of health workers one time to turn the patient back. Maybe you need 5 or 6 nurses. I think 4 to 8 hours is proper, but the longest hour we kept our patients in prone position, maybe 12 hours, 14 hours, but not longer. And we don't feed the patient in prone position.
Wow.
We feed them when we turn him back, turn him or she back.
So that's quite interesting. I know there's been a target about time, but we try to follow the target about mechanical, like the respiratory conditions, the gas exchange ratio, to decide when we change them from the prone position, or if they have minimal support from the ventilatory system, like maybe PEEP of 10 and FiO2 of 40%. In that moment, we choose to change them back to the supine position.
Yes, go ahead, doctor.
Yes, I agree with Dr. Hu. I think it's due to the different type of a very severe hypoxemia. Some patients have a typical ARDS, just as you mentioned that the lesions have a gravity dependent areas distribution, so you can get some benefit from the propositions. But if the patient have a lot of ground glass opacities, maybe you cannot be benefited from the propositions. So I think you should choose a different patient. And if the for our patients use NPPV, if the oxygen saturation cannot arrive 90%, we can detect lactic acid. If the lactic acid haven't been elevated, that we can keep relatively lower oxygen saturations, and the patient can suffer from that.
Thank you very much.
Okay, thank you so much, doctors. So, Dr. Dominguez, do you have more questions?
Yes, I have a question for three of you. How frequently do you see nosocomial infections? Because it has been seen in different parts of the world that is an increase in the number of bacterial nosocomial infections during the COVID-19. Do you have any numbers regarding this?
I'm not sure I get your question. What about the doctors here in China? If not, maybe can we ask you please to rephrase your question a little bit? Thank you.
Yes. Yeah. Because my question is regarding the nosocomial infections besides the COVID-19 in the critical care patients. Have you seen an increase in the numbers of nosocomial infections that you used to have regularly?
Yes, nosocomial infection. In our ward, it was not very common, but yes, we have nosocomial infections. For example, we had a very severe COVID-19 patient who was treated with MPPV, who was treated with glucocorticoids for many days. And when we performed the chest CT before he was discharged, we found a lung cavity. We found a cavity in his lungs, and we thought it was aspergillosis that was super infected because of using too much glucocorticoids, and we treated him with voriconazole. And at last, the lung lesion absorbed, and he was discharged. And the bacterial infection was not quite common in our ward, but it was common in the ICUs in our hospital. That was treated by doctors from other hospitals, and we heard that they used some drugs, some new antibiotics such as polymyxin, and some new kind of antibiotics, but nosocomial bacterial infection was not quite common in our ward.
Mm-hmm.
Thank you.
Thank you.
Okay, thank you. So now let's turn to the big screen to see some of the questions or comments that have been left by our followers online. So, okay, so my colleague has chose one from Weibo. So in Chinese, is 电影院重启，我们应该做好哪些保护措施？那2个小时的密封空间会不会提高传染的风险 ？So the English translation is now we know in China, the cinemas have been restarted their operation. So what kind of protective measures should be in place? And 2 hours of staying in a closed area, will that increase the risk of infection? So which doctor can help us to answer this question for our followers? 看一下我们中国的哪一位老师可以帮我们回答一下这个问题，可以提一些建议。可能现在很多正在收看直播的网友也会有类似的疑问。
I think also the experience has been proved to be very effective to protect for the transmission. Mm-hmm. That is keep social distance, to wear mask, and to wash your hand. This three aspects is also very important.
Okay.
So when you came to the cinema, you can keep this method.
Okay, thank you. It's very concise yet very helpful. So number 1, wear your mask. And second, keep your personal hygiene, like washing your mask, right, at the frequent base. Okay, yeah. So yes, Dr. Carlos, it seems you have more questions.
Look, this is a very specific question about if there is a specific way that you are using to select the PEEP in the mechanical ventilator when you are treating patients with ARDS and COVID-19.
PEEP, when using MPPV, PEEP equals to EPAP, right? When using MPPV, usually we set the parameter on experience. Usually there is, according to ARDSnet, there is a protocol of the PEEP and the inhaled fraction of oxygen. When the FiO2 inhaled fraction of oxygen, FiO2 is lower than 60%. Usually we set the PEEP around 6 to 10, and when it is higher, the FiO2 raised to 80%, 100%, and we will raise the PEEP to 10 to 18 perhaps. And when we set the parameter on experience, we will also consider the patient's figure, the BMI. If a very thin patient, we will set it lower, and very fat patient, we will set it higher, so to avoid pneumothorax in some. We had pneumothorax or pneumomediastinum in very thin patients. Well, in ARDS patients, if intubated, I prefer to use the PV curve to set the PEEP. And in patients who are suitable to use recruitment maneuver, we also can set the PEEP after the recruitment maneuver to set the most proper PEEP. Did that?
Okay, thank you.
Okay,
Yes,
so
thank you very much.
Thank you. So since we're now running out of time, so we would like to have the final question. So yes, Dr. Huan, I saw you raising your hands. Yes, the final question goes to you.
Thank you very much. So I have to choose my final question. What will be your best recommendation for our physicians in Mexico treating these patients? Like, after your experience, what will you say, this is my best report, my friendly best recommendation?
Okay, I'll go first.
Yes.
And I have two recommendations. First is do your best to protect yourself, and don't forget every procedure. Remember to follow every procedure of protection, personal protection. Only if you protect yourself, and then you can treat more patients. And secondly, I think the most important treatment for COVID-19 patients is support, respiratory support. And so don't give up, and try to treat all the complications and support his oxygenation. And if you insist long enough, most patients will get better. Thank you.
Thank you. Yes, Dr.
Yes.
Lee.
I'll follow. I think the physicians must have a great role in the protection of COVID-19. I know that they are also controversial about the wear masks in the Western countries. I think that's very important. You know, the mortality in Hubei province and the Hubei province is so difficult. In Hubei province, we have a mortality more than 6%, but out of Hubei province, the mortality is only 0.8%. And during this time, outbreak in Beijing, we have totally more than 300 patients, but only less than 20 are severe types, and only maybe 3 are critical patient accepted ventilations. So if you can keep a very good protection for oneself, maybe you can decrease the ratio of the severe and critical patient. It's very important for the whole countries. So I think maybe physicians can find their positions in the patient teachings and such kind of things. It's very important. Thank you.
Okay, thank you so much, Dr. Lee.
Thank you very much.
Dr. Wang, do you
Thank
have
you.
more to add on?
Yeah, I think the most important is to protect yourself, and this is the top for the doctors and the nurses, and I think we should be active to use the anticoagulation and care about the heart. Yeah.
Okay. So thank you so much, everyone. With that, we're going to wrap up today's discussion. And as we know, Mexico now is still going through a very tough time fighting the pandemic. And as the Mexican government said that with the capacity of testing now grows, the actual confirmed cases of COVID-19 might be even higher than what we currently have. So, but we also know viruses knows no borders, and this global health challenge can only be tackled with solidarity and also international cooperation. And that's what made today's discussion and exchanges of opinions really, really important and also protective. So, and it is also really important to protect yourself, no matter you are just an ordinary person or you're a medical expert fighting in the front line. Something, just as Dr. Lee said, even wearing a mask can really help you to prevent you from getting the disease, and also to to increase the rate of infection, and also to decrease the rate of getting infected, and also help you keep safe as well as healthy. So thank you again for everyone for your time and also your contribution, and a big thank you to our followers for your submission. We'll have more to come next week, so stay tuned and goodbye.
Thank you so much.